Hello. So we're gonna be discussing an interesting topic today, asthma. Okay, it's very common. According to Harrison's, we have over 300 million people in the world today who are struggling with asthma. Okay, asthma is a childhood illness. Okay, occurs from childhood, and then usually you have a patient who would present in the hospital. Sometimes there are three classifications. Of course, the patient could have a controlled asthma, because meaning the patient has very few to no daytime symptoms or nighttime awakenings. Okay, and doesn't really have to use a reliever all the time. Okay, and then the patient, if the patient has poorly controlled asthma, usually they have an exacerbation maybe once in a year, and they have maybe more than two or more than one daytime symptom. Okay, by daytime symptom I mean maybe they're exercising and they feel they have an asthmatic attack. Okay, an asthmatic attack. Okay, for uncontrolled at all is an exacerbation maybe almost every week. Okay, almost every week, and they have very frequent nocturnal awakenings, very frequent daytime symptoms, and they have to use relievers every time. Okay, you can see our picture here. We have a very nice picture here. We have a moon. Okay, taking you back to kindergarten. Okay, we have a moon over here. Okay, we have a little boy over here. He seems like he has some muscle. Okay, explain what that means. SOB, shortness of breath. Okay, he's of course on a skateboard, and as he's going on the skateboard, he's saying "wee" and "three." Okay, those are his words. I'm gonna be explaining this later on. Okay, so how will a patient present? Okay, a patient with asthma would present usually at the age of 3 years old. Okay, onset. Okay, they can present at any age to the hospital, but of course onset is at peak age of 3 years old. Okay, and patient will usually have a shortness of breath. Okay, um, in very bad situations, ominous sign, the patient will have to use accessory muscles, which is retractions. Okay, don't mind the biceps. Okay, that I put here. It's usually retractions. Okay, intercostal retractions, substernal retractions, and so on. Okay, a patient would usually have onset while exercising. So you can see he's on a skateboard. Okay, and he's saying wee. Okay, that's a wheeze. Okay, he's gonna have a wheeze. When you auscultate with your stethoscope, you're gonna auscultate a wheeze. Okay, and also your patient is going to also of course, like I said earlier, okay, peak onset at 3 years old. According to Harrison's, okay, it's twice as common in males in the childhood. So boys usually in the childhood, and then when they grow older, usually women. Okay, women. It's worse at night. So let's put a crescent over here. Okay, it's worse at night. So they would usually have nocturnal awakenings. Okay, they would have to wake up at night, and then of course because of the shortness of breath, there will be tachypnea or hyperventilation. Okay, hyperresonance because sometimes there can be hyperinflation. Okay, so when you percuss, you would be able to percuss the hyperresonance. Okay. Okay, so that's the picture of asthma. So asthma, there's asthma triad. Okay, remember for COPD has irreversible airflow obstruction, but of course your asthma is reversible. Okay, let's start with airway inflammation. Usually when a patient has asthma, it will be a reaction. Okay, it will be a reaction, an allergic reaction. Okay, so usually it's triggered by your IgE. Okay, so your IgE will cause activation of your mast cells. Okay, and your mast cells are responsible for bronchoconstriction. Okay, will lead into airflow obstruction. Your mast cells will also activate your neutrophils. Okay, your neutrophils. Okay, and this is mast cells. Okay, and then they will also activate your eosinophils. Okay. Okay. So your airway hyperresponsiveness usually as a result of course, when your mast cells, okay, are activated, they will secrete some chemicals like PDGF, okay, which causes smooth muscle hyperplasia. Okay, smooth muscle hyperp, okay, hyperplasia. Smooth muscle hyperplasia will cause increase in the size of your smooth muscles of your in your bronchi and your bronchioles, thereby causing airflow obstruction. Okay, There's also your basement membrane fibrosis, okay, especially in your epithelial area, okay. Your type 2 slash type 3 slash type 4 collagen will have undergo fibrosis, okay, and this will also further cause airflow obstruction, okay. And this is caused by your TGF beta, okay. Your reversible airflow obstruction, of course, has several causes. Like I told you previously, your smooth muscles are hypertrophied or have hyperplasia. Your mast cells cause bronchoconstriction. Also, your interleukin 13 secreted by your mast cells, okay, can cause mucus over hypersecretion, okay. So there's increased mucus in the lungs and in the airways, okay. Also, your vascular response can cause airway edema, okay. So how can we remember all this? Okay, remember the triad is so important. Let's first talk about the inflammation, which is fire, okay. So inflammation, fire. If there's obstruction, then we have to be thinking of maybe a road that is obstructed, okay. So somebody is trying to pass a road in his car, and then he's unable to pass the road because there is an obstruction on the road, okay. There's an obstruction on the road, and instead of him to just be calm about the situation, he starts screaming out saying no, okay. So that's his hyper responsiveness, okay. So you can remember it with this diagram, okay. Remember your IgE, okay, IgE, okay. This is your IgE is the fire, okay. Your hyper responsiveness is the, okay, smooth muscle, SM, smooth muscle hypertrophy, and then your green is also your mucus hypersecretion and your airway edema, okay. Your airway edema, edema, okay. Good. So let's go on. So your etiology can have different causes, okay, especially your allergens. According to Harrison's, 80% of patients that are asthmatics have had allergic rhinitis, okay. And let's make him think about the causes, okay. He's having an asthmatic attack, and then he's thinking of what could have caused this, mom, okay. So allergens include like pollens, okay, like cockroaches, dust, mites, okay, dust particles, smoke particles, okay, sodium, sulfur dioxide, ozone, okay, environmental pollutants, and so on, okay. Could also be caused by infections, okay, especially your rhinovirus, okay. Also, if a patient has pneumonia or mycoplasma infection, okay, lung infection, is going to lead to an asthmatic attack, okay. It could also be genetic, okay. It's polygenetic, meaning you cannot point to a single cause. So this is a DNA, a double strand, okay. Exercise, you can see our patient here is on a skateboard. Whee! So he's shouting whee, okay, and 3, okay. He's 3 years old. Okay, and of course, as he's going down on his skateboard, there's going to be a blast of cold air, okay, which can be a cause of a trigger medications, okay. So let's make him think about some medications, especially aspirin, okay. Aspirin, also your beta blockers, okay, and your ACE inhibitors, okay, can be a cause, okay. Allow me to include also stress can be a cause of your asthmatic attack. So patient heard that her parent or family just died, okay, can cause an asthmatic attack. Funny enough, according to Harrison's, it says that excessive stress improves asthma, okay. Severe stress, okay. Normal stress can cause asthmatic exacerbation, but severe stress improves asthma. Don't ask me why. Okay. So next is your diagnosis. So how do you diagnose? Okay, you can diagnose with your PFT, okay, pulmonary function test. Your FEV1 to FVC ratio is less than 0.70, okay. You can do a spirometry, okay, because remember that the airflow obstruction is reversible. So of course, if it's reversible, if you give your patient albuterol, which is a short-acting beta 2 agonist, it should cause an improvement in your FEV by 12% in 15 minutes, okay, 15 minutes, Okay, remember this so you don't expect this in 5 minutes and say and conclude already. 15 minutes. Okay, and then you can do a bronchoprovocation test. So usually for your bronchoprovocation test, if you give an ACH agonist, okay, which causes bronchoconstriction, you should have a decreased FEV1 by 20%. Okay, so you only use a bronchoprovocation test if you think that your patient has asthma, but you have a normal PFT and normal PFT. Okay, but you really think that, oh, this patient has a history of asthma before, but his PFT is normal and you're not so sure, then you gotta do a bronchoprovocation test. Okay, so your peak expiratory flow rate, usually this patient is usually used in the emergency setting. Okay, sometimes patients can use this from their home, and when they present at the hospital they say, hey doc, my PFT is actually this. Okay, for your chest x-ray you expect to see hyperinflation. Okay, hyperinflation. Why is this? Because there can be air trapping. Okay, because there is airflow obstruction. Okay, and in your ABG, think about it, guys. If somebody has difficulty breathing, okay, they will definitely have hypoxemia. Okay, reduction in the O2 sat. Okay, of course, if it's less than 90, if it's less than normal, you should already put them on oxygen. Okay, apart from hypoxemia, when the patient has hypoxemia, the body is going to react by, okay, causing hyperventilation. Okay, so which will explain why the patient has an increased RR, respiratory rate, tachypnea. Okay, and with tachypnea comes hypocarbia. Okay, because as the patient breathes faster and faster, there's less CO2. Okay, so warning sign: if a patient has normal or increased CO2, okay, hypercarbia, it means that the patient has impending respiratory failure, because hyperventilation usually is a response, okay, to your hypoxemia, a response to your reduction in your O2 sat. Okay, so if a patient already has normal CO2 or increasing CO2, it means the lungs is unable to cope. Okay, and the response is a failed response. Okay, so you have to intubate already. Okay, you have to intubate already. Okay, so how do you manage a patient? Okay, so it's classification and management. Okay, remember for COPD we use the Goldman classification. For asthma, okay, you can classify based on three major classifications. You can classify based on your FEV1, your daytime symptoms, and nighttime awakenings. Okay, for your daytime symptoms, if you have less than 2, for your mild intermittent you have less than 2 per week. Okay, and then you have less than 2 per month for your nighttime. Okay, for your nighttime awakenings. Okay, so as you go to mild persistent, you have normal FEV1. According to IMPLAT, it says FEV1 usually 0.75 to 0.80. Okay, you have less than 1 per day. Okay, which means that you don't have every day. You don't have daytime symptoms every day. Okay, this is per day, not 11. Okay, and then here you have greater than 1 per week, meaning your patient will complain that they are woken at night at least once per week. If it's more than 2, if it's more than 1, it's already mild persistent. Okay, and then for your merge rate, you have FEV1 is already dropped wide, which is why you have to do your PFT. So it will be greater than or equal to 1 per day, and then greater than or equal to 1 per day per week. Okay, per week. Okay, and then for your severe persistent, it's going to be greater than or equal to 1 per day, and then frequent. Okay, frequent, which is severe persistent. Okay, so what medications do you give your patient? Okay, you have to give your patient, first treatment is your SABA, okay, your short-acting beta-2 agonist. Okay, as I talk about the medications, I'll talk about the side effects, talk about the actions. Okay, so SABA is a bronchodilator. Okay, it's a bronchodilator, binds to the beta-2 receptors of the lungs and causes activates adenyl cyclase, increasing the cyclic adenosine monophosphate, increase CAMP, and then thereby leading to bronchodilation. Okay. Side effects: causes tremors and palpitations. Okay. So for your mild persistent, you can give your SABA and add an inhaled corticosteroid. Okay. Example of SABA: albuterol, okay, salbutamol. Example of inhaled corticosteroid: your inhaled corticosteroids, you can give inhaled corticosteroids. Basically reduces your inflammation. Okay, they are anti-inflammatory agents. Okay, and example of inhaled corticosteroids is budesonide, okay, or fluticasone. Okay, for your moderate persistent, you can give a SABA, okay, and your ICS plus your LABA. Remember, do not ever give your LABA alone. Okay, don't give your LABA alone. Example of LABA is your ipratropium bromide. So these things are anticholinergics. Okay, so basically they also cause bronchodilation, but it's longer term. Remember, your SABA begin to work 4 to 5 minutes after use. Okay, LABA acts much longer. Okay, so you have to use your LABA if your patient is already moderate persistent, because of course they have more nighttime awakenings. So you want to reduce, of course, forgive me, for your goals, for your management of your asthma, you have to reduce your daytime symptoms, reduce your nocturnal awakenings. Okay, reduce the side effects of your medications. Okay, and generally give the patient a better day-to-day living. Okay, for your side effects of your inhaled corticosteroids include oral thrush. Okay, oral thrush and hoarseness of the voice. Your side effects of your LABA is dry mouth and urinary retention. Okay, so for your severe persistent, you can also give SABA also, but you can an ICS plus LABA, but you can increase the dosage. Okay, you can give your medium dose ICS or high dose ICS. Okay, so there are other medications. Of course, there are non-pharmacological management, which include tell the patient to stop smoking, okay, breathing exercises, avoid triggers and allergens, okay, and help tell them to exercise. Of course, if exercise is the trigger, you can give other medications, which include cromolyn or chromones. So chromones are mast cell stabilizers. Remember, your mast cells are responsible for your bronchoconstriction. So your chromones will help to prevent your mast cells from causing bronchoconstriction. Okay, your chromones or cromolyn usually are used when you're sure that exercise is the trigger of your patient's asthma. Okay, you can also give an anti-leukotriene such as montelukast. Okay, montelukast, it's an anti-leukotriene. Okay, and now lastly, you can give theophylline. So theophylline basically inhibits phosphodiesterase. Okay, inhibits phosphodiesterase. Okay, so basically the most common ones are the medications I've given above. You can also give sorry, I'm getting the pronunciation wrong. Omalizumab. Okay, omalizumab. Okay, IgE, omalizumab. If a patient comes in with asthma exacerbation, you can of course you have to give the patient SABA, ICS. You can give oral corticosteroids. Okay, you don't anymore have to give inhaled. Okay, give systemic like prednisone or methylprednisolone. Okay, so again, here are the examples of your short acting, long acting, and combinations. Okay, all right. Did I leave out anything? No, I did not. So this is your asthma.